we have Dr. Candice Todd joining us. Some of you may recall she presented last year around this time as well. Dr. Candice Todd is a general neurologist and a headache medicine specialist at the Scarborough Health Network in Toronto, Canada. She completed her residency at the University of Toronto and completed her fellowship in headache medicine at the University of Toronto. Dr. Todd is interested in women's issues in neurology, specifically pregnancies and its impacts on headaches, as well as gender and racial disparities in neurological diseases. And with that, I'm going to turn it over to Dr. Todd.
I just want to thank Migraine Canada for asking me to do this again this year. Update, I'm also now at Women's College at the Center for Headache. So if you can't find me at Scarborough, you can find me at Women's College. Last year, we talked about kind of a lot of things. We talked about headache through a woman's life, pregnancy, perimenopause, and the postmenopausal state. But I think that the perimenopausal state is a really interesting one. And I think from the interest, it's the state that is the most interesting to most of my patients these days. So hopefully I don't spend too much time talking and you guys can all ask me questions if you want to after. In terms of disclosures, I give talks to, family doctors and other neurologists, and they are sponsored by pharmaceutical companies, but we're not specifically talking about any medications today, so this should not impact the talk whatsoever. The objectives. I'm hoping that we can touch on all 8 of these points, and I think the most important piece would be, points 8 and 7, because I really want, it looks like you are all from various places, not directly near me, so I can't see you all. And so it's important to kind of have an idea of what you're going to go back and talk to your healthcare practitioner about, should you be concerned or should you want further help with your headaches. So, migraine in the perimenopausal period is quite frequent. And we know that migraine is very common in individuals that have the capacity for pregnancy or biological women, and that's in comparison to biological men. The average age of a young girl's period is about 12 and a half years old, and that often coincides with the beginning of migraine. So I don't see a lot of pediatric or children, but when I do, it's often, in the 8 or 10-year-old young lady age, they start presenting with headache, and then shortly after they do get their period. And so it's kind of the same in women that are entering the perimenopausal period. And often my patients will come to me and say, I have a history of high frequency headache or low frequency migraine, and all of a sudden things are just out of control. And, we do imaging and we do blood work and we can't really find a clear reason. And in the end, it's not so dissimilar to the young girl that's getting worsening of her headache before her first period. There's a hormonal imbalance. It's throwing things off. And especially in especially in women that have migraine around their period, or they get migraine worsening with ovulation or migraine with aura, there's clearly a hormonal component or a hormonal piece to their headaches. And that's typically when we see worsening of headaches is leading up to menopause. And we'll talk about the perimenopausal state, but that can last anywhere from 10 to 15 years. So what I can hopefully drive home to you is that when you're in the perimenopausal state, headache absolutely can worsen for many people, and it often does. The other thing I will say, just as an aside, is there can, in young girls, there can be, more stomach pain and abdominal pain, or abdominal migraine, or they call it, or worsening motion sickness. You can also get a little bit of that or worsening of that in the perimenopausal state as well. So like I said in the previous slide, migraine affects close to a quarter of perimenopausal age women. That's a huge amount. And onset of migraine can really happen at any age. There is some literature, some data on first presentation of migraine in individuals 60 plus, which is not common by any means, but it is within the realm of possibility. migraine is typically the most active in individuals less than 50. And we do want to think that, perimenopause has a lot of changes overall in your body. And, with perimenopause, you can get worsening mood issues, so anxiety and depression. You can get worsening of your sleep, and that can also contribute to worsening of your migraine, because really migraine and headaches are very sensitive to changes in lifestyle and balance. And so that could even be a tipping point in and of itself for worsening of your headache. I do think if you have a history of low frequency migraine, you're only having migraine a couple times a year, and all of a sudden things, start flying out of control and the frequency really ramps up, you do still warrant investigation, plus minus imaging of the head. And that's really up to the healthcare practitioner and based on the history you provide and your examination to determine whether you need further imaging. But I often do some blood work, like checking your vitamin D level and your iron level, just to make sure that there isn't something else that's driving the worsening of your headache. There was a study that was done by the AMPP, or it's an American Migraine Prevalence and Prevention Study. And really what the literature shows is that there's often a worsening of headache during the transition to menopause. And usually postmenopause is associated with relief of headache, but that's not always 100% true all the time. What I say to my patients is how you enter perimenopause really dictates how you're going to exit it. And so it's always good to be prepared and to, seek out a healthcare practitioner if you feel like the headaches are starting to ramp up and get a little bit out of control. Because there is medications, there are treatments now for migraine, and you really want to get a good handle on things before they get too crazy in terms of frequency and intensity. I will say the type of menopause is an important consideration. So migraines were 40% less common after what we call a natural menopause as compared to premenopause frequency. So, the type of menopause has an impact. So, early onset menopause, which is considered in women less than the age of 45, has been linked to somewhat worsening of headache, especially surgical menopause. If you have a hysterectomy and an oophorectomy where they take out your ovaries, you have this really dramatic loss in estrogen, and that can worsen headaches. And, if you don't have estrogen, if they don't add back estrogen to you after the oophorectomy or after the removal of your ovaries, that can often produce worsening and even more disabling headaches. So it is, preventatives, which are considered medications that you would take on a daily basis for migraine, were used most in the late perimenopausal stage, and we'll talk about why that is. But often, I think the gist of this slide is that headache can definitely worsen during the perimenopausal period. And it really depends on the type and the timing of your menopause. So what is perimenopause? I think most, if not all of you, know what perimenopause is or have heard of perimenopause. I think there's just some verbiage that goes with it. So really, menopause is one day, and it's really the day that you stop having a period for 1 year. And then everything is either before menopause or postmenopausal. And, menopause, perimenopause can really start anywhere, but it's typically after the age of 45. It can last 10 to 15 years. And then postmenopause is postmenopause forever. And that's really where you stay for the rest of your life. You don't have a period anymore. You still have a little bit of estrogen floating around, but not really enough to be too bothersome. But in the postmenopause period, you have enough estrogen and enough adjustment to your hormone system that you can have persistent night sweats and hot flashes for a period of time, even after menopause has come and gone. And, the perimenopausal period is really what we're going to talk about, and the hormonal soup. So the red depicts, the estrogen levels throughout your life. Progesterone is less impactful. And then the kind of fuchsia or pink squares are the menstrual periods. And over time, they become irregular. And you can start having longer menstrual cycles, shorter menstrual cycles. You could go months or weeks without having a period. And that's really what leads to the worsening of headache in many women. So I think of it like a soup. And like I said in the previous slide, perimenopause or menopause is, one day where your period is, you haven't had a period for a year. And like I mentioned again in the other slide, you can have a menstrual cycle that, is starting to get longer, more than 7 days. Your period goes, anywhere from you're missing 2 months at a time, 3 months at a time, or you've missed greater than 2 periods in the last 12 months. Those would be kind of clues that you're maybe slowly entering into the perimenopausal state. And the takeaway of this, if you get nothing, is that it's a soup. It's a hormone soup, and every week and every month is something different. And as the estrogen levels slowly die off, that's really, well, it can often be a big trigger for women and worsening headache. What is a migraine? I think that we take for granted, I take for granted, that everybody knows what a migraine is. And I think that the labels do and don't matter in some ways. So for me in my clinic, I obviously want to diagnose you with a migraine, and that's usually one half of your head. And it can be either side, left or right, is typically in pain. Although in individuals who have chronic migraine, it's often their whole head. Sometimes they feel like the hair on their head, the hair on their scalp is tender. It's moderate to severe. And that really means you're not showing up to the emergency department for a tension type headache, right? People don't go to the emergency room and wait 16 hours for a tension type headache. It's really for migraine. So it's that bad. And you tell me you're going to the emergency department, I'm going to assume that it's likely to be migraine. You don't want to do anything. You're missing events. You're missing social functions. You're missing work. You're missing school. You're making an alteration or an adjustment to your life because of the headaches. The other pieces, nausea and or vomiting, you can have either or. And then you should have light and sound should bother you. So that's the photophobia, which is light, and phonophobia, which is sound. And it may not be super striking to you. You may just think, fluorescent lighting is a little bit bothersome when you have a bad headache. You never may have noticed that light bothers you, but you do prefer to rest in a dark, quiet room. You don't want to be at a party. You don't want to be in your subway or transit or go to a concert because the sound is bothersome. That would be the clue that you have light and sound sensitivity with your headache. That's just migraine. And then there is this aura or this visual or sensory disturbance that people can often get with their headaches. And that can really be a bunch of stuff. I think the classic is, the vision changes that people can get. And that can be bright lights. Some patients describe kind of squigglies, kaleidoscope. Some people can even get tingling of the arm. Sometimes they feel like the speech is garbled. That can all be aura. The key piece with aura is that there's a time frame for it. So it can't last seconds. It's got to be at least 5 minutes. It's got to last no more than an hour. So 5 to 60 minutes. And you can have multiple different symptoms with your headache or with your aura. The aura typically happens before the pain starts. But I know that many people, don't pay attention. And once the pain starts, then they're like, oh, wait, I think I can't see perfectly clear out of my left eye or my right eye. You can have blurred vision. You can have vertigo or dizziness with your headache. And that's not necessarily always an aura. I think it's important, and we'll talk about why it's important to be clear and make sure that your healthcare practitioner is clear as to whether you have aura or not. Aura can increase your risk of stroke, and you have to take in other risk factors with it. But if you're someone in the perimenopausal state that has a lot of hot flashes and night sweats and you're considering hormone replacement therapy, that plus aura could potentially increase your risk of stroke. So that's why when I see patients and they describe, visual or sensory symptoms, I'm very clear and try and get as detailed of a history as I can, because once you're labeled with having an aura, it really changes your management and it changes your ability, or rather it changes the therapies that are available to you. So whenever you see your healthcare practitioner, just be very clear as best as you can with the symptoms that you're having. And I find a headache diary, which Migraine Canada has lots of, or just writing on a calendar or piece of paper, trying to be very clear about your symptoms and when they're happening, just so your healthcare provider can be as detailed and as clear as to what you're experiencing as possible. The reason why I added this slide is because often when I see people in the office, they really want to know, like, what is wrong with me? What is what is the cause? Is there something wrong with me? And the answer is there's nothing wrong with you, but migraine is an inflammatory or an inflammation disease, just like rheumatoid arthritis. It's not similar to diabetes, but it's a disease like any other. And I think that there's a lot of stigma associated with migraine amongst healthcare providers, amongst friends and family that don't really understand it, because it's not like we can do a CT scan and diagnose you with migraine. It's not like we can do blood work that we can follow and say, yep, they have migraine. And it really is and can be an invisible disease. We know that there's a genetic component to it. We have genes for certain types of migraine. And we know that there's what we call an inherited or heritable component, meaning that, I always ask, does your mom or your aunts or grandparents have migraine? Do your kids have migraine? Because it often runs through the family. And so we know that there is an inherited component to it as well. And really, what is a migraine? It's connectivity dysfunction. And that can increase your risk or increase your sensitivity to lots of stimuli. So many of my patients say, the sun is too bright, that can, trigger my migraine. You're just sensitive to environmental factors that are present at all times. A normal brain is able to block out signals that do not benefit them. But in a person who has migraine, you're always hyper aware. Dr. Lay, who's the head of the Center for Headache at Women's College, I was her fellow. I did a fellowship in headache medicine. She always said that people with migraine are evolutionarily more advanced, meaning, migraine people are able to perceive danger faster than someone like myself who doesn't. So you're able to perceive light and sound better than someone like myself. And evolutionarily, you are more advanced. And although you may not feel like it, it makes you hyper aware. You are always in survival mode. And that can be really disruptive to someone on a day-to-day basis. There is a link, and we're not going to get into it too much today, but there is a link between what we call adverse childhood events or trauma. And these ACEs happen before the age of 18. And that can be anything from, what you didn't get enough of as a child or what you got too much of. Whether you were sick, whether you had, verbal, physical abuse, whether you traveled and fled a country, it kind of causes certain parts of your brain as you're developing to become in this overdrive situation. And that's why many individuals with migraine have what we call comorbid, or they have anxiety or depression, or they have other mood symptoms, because that's all the same pathway. And your brain is just in this hyperdrive or overdrive state. There's a really good book if you're interested in understanding a little bit more about adverse childhood experiences or ACE or trauma. It's called The Body Keeps Score. I have no affiliation with them, but I've had a lot of patients that have read the book and found that it's been very informative. This bottom point I just talked about, or I highlighted interictal burden, which is just a fancy way of saying that in between the migraine, people, the actual migraine pain, people are disabled and still have difficulty participating in their activities of daily living, going to work, saying yes to social functions. And that's because, they are just not able to function in between a migraine, during a migraine. And so I think what we do need to, places like Migraine Canada and just through further advocacy, we really just need to get the point out that migraine is incredibly disabling, and that we really need to start focusing on patients, better and, screening for migraine and treating migraine patients better overall across Canada. So hormonal changes in migraines. So again, it is a soup of hormones, and estrogen is not all good and estrogen is not all bad. So estrogen is, as I'm sure you're all aware, very vital hormone. It can impact how we feel pain. It can impact, obviously, headache. It can cause dizziness, nausea. We have an internal thermometer that gets adjusted during the perimenopausal state, and that's what causes the hot flashes. Our body is just trying to offload all the heat. Our thermometer is higher than what it should be. It naturally is going to impact mood. And estrogen truly is a game of balance. You have a positive and negative effect on the brain, and perimenopause skews that completely, and you start becoming more net negative. And that's really what contributes to the hormonal changes and the worsening of the migraine. And estrogen is not necessarily a huge factor for everybody. And like I said, estrogen can be a big factor for individuals who have migraine with the aura symptoms. If you had a history of worsening headaches around your period, that could be, a big trigger for you. Perimenopause could be a big trigger for you. Women who had a lot of what we call premenstrual symptoms may be more sensitive to the fluctuations that you get during perimenopause. And, you just have to kind of be able, I think half the battle is just being able to identify what's going on and kind of tracking your symptoms in order to kind of be able to describe them and ask for help from your healthcare practitioner. Hormonal. So perimenopause and migraine exacerbations appear most pronounced in women, like I said, with a history of menstrual migraine, which we just talked about. The interesting piece is that, like I said before, many women will come to me and say, once I go through menopause, I will hopefully not have any more migraines. And I do hope that for everybody. That's not always the case. What I will say is those individuals that have low frequency headache are the most likely to lose their migraine features and no longer, we say, diagnostic criteria. They no longer fit that criteria for migraine as they transition into menopause. The diagnostic criteria is that moderate to severe in intensity, light and sound sensitivity, nausea and or vomiting, throbbing, pulsating headache. They may lose those characteristics. Some women can have higher frequency of headaches with a decrease in migraine. So they can, have more, they could typically be, have a lot of migraine all their life and then have higher frequency headaches during the perimenopausal period or vice versa. I think the point of this slide is that there's no guarantee and there's no rules. You could basically be anything during the perimenopausal state. And so the belief that things go away right after menopause is not necessarily true. But again, I believe that how you enter into perimenopause and how you manage your headaches during perimenopause can really dictate how you leave perimenopause. So I think the important piece is, how do you manage migraines during perimenopause? So since being a fellow at Women's College now 3 years ago, the medications that I had available to me and during my fellowship have exploded and have tripled. So we have a lot of migraine specific medications on the market. And, if you were someone that did not have a good response to medication in the past, know that there still is hope and there's a landscape of medications now available to us now. Hormone replacement therapy, that was a question that I got a lot of last year. And I think that HRT or hormone replacement therapy has a really great purpose for many individuals. The only thing I would say is that we want to be mindful if you are someone that's going to start HRT, that you are aware of the potential impact that it can have on migraine frequency and severity. So if you are an individual that has migraines that are triggered by hormone fluctuations, so your period when you ovulate, HRT could, in theory, stabilize things because it's providing a steady amount of estrogen to you, and that could actually make things better. But if you have migraine with aura or menstrual migraines, HRT could potentially worsen things. So it's really a mixed bag, and it's really dependent on the type of migraine, again, that you have. The type of HRT is important to understand. So, estrogen only therapy can be more suitable for women who've had undergone a hysterectomy. Combined tablets, so estrogen and progesterone, is often prescribed for women who have a uterus still. Progesterone is I like progesterone only options because it's a nice kind of safe hormone to provide, and that can kind of level the estrogen fluctuations that you can get in some individuals. The route of administration, and what I mean by that is we've got lots of different ways to get estrogen. So a tablet usually is a little less stable, and you can have more fluctuations in your level. The patch is a little bit more preferred. Obviously, I'm a big fan of, local administration. So if you're someone who has a lot of vaginal dryness and sexual dysfunction, local estrogen topical gels are never a bad idea and has less impact on migraines as a whole. And you really want something that's going to provide as stable as you can level of estrogen in the system, because again, it's that fluctuation that's really triggering migraine for many people. Individual risk factors. I bold that because that's really the space that I live in as a neurologist. I don't prescribe HRT. I don't manage HRT. No neurologist really should. But what we do, what I often get asked is, what is the risk of stroke? And that really is what it all comes down to. So, the things that I take into account is obviously age, medical history, meaning do you have a history of high blood pressure or cardiovascular disease? The type of migraine that you have. Are you someone that has migraine with aura? Because that increases your risk overall of stroke. Do you smoke? Have you ever had a clot? Frequent miscarriages? These are things that I'm always asking because, estrogen therapy may increase your risk of a heart attack or stroke overall. And so we just really want to be the safest that we possibly can be, as well as make you as happy as you can. And I understand that, the night sweats and the hot flashes and all that are awful. And we want to make sure that, you're able to function and be happy for those 10, 15 years. It's not a short period of time, but we also need to mitigate or reduce the risks of serious medical complications. And then the most important thing is if you are going to go the HRT route, you really have to have someone that is going to monitor you closely. And you really have to find someone that you're able to follow up with, that's going to check your hormone levels, are going to be knowledgeable enough and assess your migraine or your headache symptoms to make sure that you're not having any worsening aura while on the HRT therapy, or you haven't developed a new neurological symptom while being on the HRT medication. So you really want to just find someone that is able and willing to follow you a little bit closely. You do not need to be in your family doctor's office on a weekly basis. That would be crazy. But I think being able to have access and having a practitioner that's willing to kind of follow you along closely is important, especially if you're someone who has migraine and other risk factors. Alternative therapies, I'm going to talk about on the next slide. So I'm just going to get to that. Okay, so I love living in the space of alternative therapies. And what does that mean? It really means lifestyle. And for anyone who sees me in my office, I usually give you a headache tip sheet. And on that tip sheet has various lifestyle strategies that seem simple in theory, but are not always simple. So, getting regular sleep, screening for sleep apnea, especially if you're someone who has morning headaches, making sure you're getting enough water. Protein is key. And I always say a gram of protein for every kilo. Some people that are very into fitness will say a gram of protein per pound. That could seem a little crazy. So I say a gram of protein per kilo, but you want to make sure that you're always getting a good source of protein within an hour of waking. Reducing screen time, trying to manage stress, meditation, prayer, yoga, whatever you can do that can fit into your lifestyle. Nutraceuticals, I know that many patients have had huge gains in terms of control of their headaches with nutraceuticals. And what does that mean? We have kind of five vitamins that have good-ish research evidence behind them. So that's magnesium, B2, coenzyme Q10. There's a small body of evidence for butterbur. Melatonin, believe it or not, has some evidence in headache. And so there's various nutraceuticals that have been proven to be helpful. If you're a little bit on the olderish scale and you can't use, Advil for whatever reason or another anti-inflammatory, or you have a lot of aura, magnesium is really wonderful for many patients. And I find that that's probably, if you're going to start one vitamin, that would probably be the vitamin to consider. I also have patients that do really well with acupuncture and cupping and fascial stretch and, whatever you find that works for you, and we can reduce the amount of medications that you're using, I'm always very much for. I like to think of alternative therapies and pharmacological therapies or medications. It's all kind of working in synergy. You really can't have one. I mean, I like to think that you really need to use medications and, lifestyle, nutraceuticals, acupuncture, kind of treating a patient holistically, and that you really shouldn't just be doing one thing. I'm getting to the end of my slides, which I think is pretty good. So the importance of seeking medical advice. I think the first step is seeing someone and getting a diagnosis of migraine if you haven't already had one. It's interesting because I have quite a few patients that have come to me in the perimenopausal state, and they have had migraine since they were 12, and they were just told that that was something that you just needed to live with and deal with. And that is by far the furthest thing from the truth, especially the landscape at the moment. There's just never been I wouldn't say a better time to have migraine, but it's never been a more exciting time, especially as a headache physician, to be practicing in this space, because there's just so many options available for me to provide to my patients, which is great. I think patients come to me often with labels that they've been given or labels that they think they have. And I think it's just better for everyone to have a good assessment, agree on the labels that you've been provided so that when you know, as you go through perimenopause, as you enter into the perimenopausal state and then leave it into the postmenopausal state, everybody's on the same wavelength, everybody has the same game plan, and you yourself are able to identify your triggers and be able to talk about your symptoms and be able to manage them as best as, you know, as you possibly can. Like we said in the beginning of this presentation, really migraine is individualized. I'm sure, you know, if you have migraine and your daughter has migraine or your son has migraine and you use similar medications, there is some there that is real. Like one family member may respond really well to the same medication. But the thing that I like so much about my job being a migraine specialist is that it really is tailored and it's individual to the person. The combination of medications, when to try one versus another, is really 100% unique for every patient that I have. And so you really want to find someone that looks at you as a whole and says, what is the best game plan for you in the time of your life? And so you really just want to find someone that's willing to listen to you and provide you a diagnosis and a treatment plan. The second last slide. So what type of practitioner is most suitable for you? I think the simplest, because everybody comes from different places in the country, is you just want to find someone that'll listen to you. And I think I know it's a lot harder than what it sounds. So, you know, you just want, you know, your family doctor or a nurse practitioner to just listen to you. And maybe sometimes you have to make a special appointment and carve out time just to talk about your headaches. I do a lot of talks for family doctors and neurologists. And family doctors, from what I've gotten as feedback, is it's not something necessarily that they are screening for. Some absolutely do, but many don't. And they're really waiting for you to come to them and say, listen, these headaches are getting out of control. I want help. And so you just need to find someone or carve out time to kind of have that conversation with your healthcare provider. The training for headache is ever changing in neurology. And as a resident, you know, I was lucky because I was at University of Toronto. We have, you know, we have headache clinics, we have headache fellowship. And so I had a lot of exposure, and my colleagues who are not headache medicine specialists also had exposure to headache. So many neurologists maybe don't have a subspecialty in headache, but they have an interest in it. And so you can definitely ask to be referred to a neurologist, and at least they would have some kind of path for you to follow, can at least provide you a diagnosis with or without migraine, and hopefully start medications. Migraine specialist, someone like myself, we are not very common. In Canada, there's not too many of us, but we're in every-ish province, I want to say. There's one of us around somewhere. Obviously, I think we're more densely populated in Ontario, so anybody that is in the GTA or surrounding area, there's at least 5 of us kind of kicking around. Outside of Ontario is a little bit more challenging. And then if you want to find someone that has a special interest in women's issues and headaches, that's also exceedingly uncommon and not many of us. But I think your best bet would just be starting with your healthcare provider and just starting to have the conversation. There's more resources out now in terms of diagnosis and management. And if they get out of their comfort zone, there should be a neurologist in your nearby area that hopefully you can be referred to. Advocacy. I always like adding this slide because, again, there's still so much stigma. And I think, you know, Migraine Canada has been such a great resource for many patients to kind of seek out help. These webinars hopefully are helpful for people, and just, you know, getting the word out in terms of, you know, what is migraine and how do we treat it. It's still incredibly underreported. Like I said, most patients don't bring it up to their primary care physician. You know, even physicians don't necessarily find headache the most attractive disease, and many practitioners shy away from it because they're not interested in it. I think the best thing for migraine as a whole is we just need more headache specialists. We need more research. We need to continue to advance the field. But for you all, I just hope that you continue to just try and get help. And if you get roadblocks, keep pushing. And eventually you will find someone that will listen to you and help you.